Um, e- Eating disorder. So my project, I'm going to talk about anorexia nervosa. You have so many eating disorders out there, and some of the most common are anorexia nervosa. For the case of this presentation, we're gonna be using uh, AN as the abbreviation for anorexia nervosa. Okay, so according to the Mayo Clinic, anorexia nervosa is an eating disorder which is characterized by low body weight and intense fear of gaining weight, and distorted perception of of weight. It's mostly common with girls because they have like this idol. It's mostly common with females because they have this idol body. Everybody wanna look like the Kardashians. They wanna be slim. They have a particular way the society looks at them, and it's also, in as much as it's common with girls, I think some guys also experience anorexia nervosa. They want to have six packs, and as a result of this, they tend to restrict their food intake, and in general this affects their metabolism, and it affects fluid and electrolytes, and other key nutrients that the body needs in order to survive. People perceive weight differently. Some people are eager to gain weight, whereas some people, like, they feel very uncomfortable about their weight or their size. Some people will look at others and like, hey, I want to be like this person, or hey, I want to be like this person, and stuff like that. But we fail to understand that we go through our own situations, and it is stressful for some people, and people don't even look at it like a mental disorder, or a psychological disorder. Yeah, it is. The awareness about anorexia nervosa is not that known, and I think we need more sensitization of the public about it, and it is very important that we always eat. Food is good. So for the epidemiological factors, most often, we feel inferior, or we let people define the way we should look, and we always want compliments from people, or like we want approval about our body shape, and which is not the best. We always need to feel positive about ourselves, and uh, if we don't have the ideal body shape that the society sees as the best shapes out there, it always creates things like inferiority complex if we do not meet to the societal norms. Most young men of this generation, like I said earlier, they would like to have things like six packs, and most young ladies, they would like to be like the Kardashians. The but the body shapes we all desire and we all wish for comes in different, comes with different price tag on it. Yeah, it comes with a lot of sacrifices, which is most often is to our own disadvantages. Um uh for example, if you start restricting the your intake of maybe fluid and food, it can affect your fluid and electrolyte imbalances, and you might lose key nutrients such as potassium and sodium and stuff like that. And also financially, it also has a financial burden. Like, some people will prefer to go do surgeries to attain the desired body shape they want, which some of these surgeries are very costly. Some could be ranges from at least $10,000 to maybe $25,000. And most often surgeries like this they pay with cash, and which is a huge financial burden to some people. Um, uh, so some may argue that when it comes to the etiological factors, some may argue that gene has a role in eating disorder, but according to the Mayo Clinic, it is believed that gene play a role in anorexia nervosa. How does it play a role? Like they say, although the particular gene involved is not yet known, um, some people may have this desire for perfectionism, and they may want their body shape to be perfect in the eyes of others. So the gene plays a role in that perfectionism aspect, and the perfectionism aspect make these people to decide to be like, hey, I want to be perfect, I want to be like this, I want to attain this shape. So they have in their mind that's what they want, that's the picture they have painted. And you know it makes them towards doing certain things that will reduce that weight, thereby affecting them in general. So and some occupations like modeling, athletes, they play a key role in anorexia nervosa. Like athletes, maybe they will be like, oh, you need to be slim to be a runner, or you need to have this particular body shape to be a model. So they also play a key role in anorexia nervosa. So for the pathophysiology, that's like a scientific explanation of how everything comes about. Um, One would think anorexia nervosa is just an eating disorder caused by maybe the fear of gaining weight. No, it's not just the fear of gaining weight. There is a lot of evidence-based practice, and there's a lot of scientific evidence. This scientific evidence, would uh, this could be a totally wrong, because there exists a science information which says an erosion nervosa has a neuroscience origin as well. And anorexia nervosa has long been associated with faulty reward process in the brain. Um, so, like in the brain, there is this dopamine activity which plays an important role in the reward system of the brain. And uh, this reward system, if it is altered, in both if it's altered, it both affects eating disorders such as anorexia nervosa and bulimia nervosa. So I'll continue with the pathophysiology and the neuroscience. Like okay, as I earlier talked about the reward system of the brain, which is dopamine. So for example, like in a normal person, after upon the presentation of food, there's this excitement, and like, hey, the food is delicious, you would like to eat and stuff like that. But people with anorexia nervosa, it is different. In the presence of food, they may be anxious, angry, or they might have mood swings, because maybe they look at this food and they're like, oh no, if I eat this food, I will not attain my body shape or my body size and stuff like that. So dopamine plays a key role in this. So it alters, they have altered reward system. Normally people see food and they are excited, they are happy. But people with anorexia nervosa, when they see food, they are they are not that happy. Yeah, they are anxious. So it might also be related to the release of a neurotransmitter dopamine in the dorsal stratum that triggers anxiety rather than the pleasure that many of us feel in the presence of food. I got this from the Vicalos et al. 2021. That's a good textbook. You can read more about anorexia universal from that textbook. So when it comes to the epidemiology of anorexia nervosa, um, due to methodological issues, like the way of research, the way research is been the way research is being carried out, um, it poses it poses a great issue with anorexia nervosa, or maybe most eating disorder. So due to methodological issues with continuous denial of diagnosis of people with anorexia nervosa, it makes epidemiology studies difficult and very costly. In so doing, many epidemiological studies use medical records from hospitals in circumscribed areas. So it's mostly in areas where there exists information about anorexia nervosa that people, researchers can really use that data, because and those areas are really small, so it makes the sample size not that big. But in general, it makes the sample size relatively small. um it gives us, uh, at times I cannot say faulty, but I will say the result is not a perfect representation of the entire population. So this most of because of the little sample size or the sample frame, um, most of the results are not a perfect representation of the entire population with on the entire population about anorexia nervosa. So the epidemiology, that is the in epidemiology, for the sake of this research, is divided into incidence, prevalence, and mortality. So we're going to start with incidence. Okay, so for the incidents, right? So incidents greatly help in providing clues of the etiology of anorexia nervosa, and incidence is also defined as the number of cases of AN, which is anorexia nervosa, expressed as per 100,000 of persons in a year. So, a research was conducted by Martinez Gonzalez et al., and 31 studies were published from 1980 to about 2019 on incidence of AN in female, mainly in Western countries, which shows varying results because of different methodology used. So there are so many research methodology out there, and there is no universally acceptable type of methodology to use. So different researchers have different kinds of methodology, and with different kinds of methodology, it affects maybe the result, because they cannot be this coherent result. Maybe research A will say this, or maybe research A will say that, based on the different sample frames and the sample sizes. um Based on that research which was carried out, the research I'm using in this presentation, an incident rate of 120 per 100,000 among Swedish females aged 20 to 23 years. So, amongst females ages to 20 to 23 years in Sweden, the incidence rate was about 120 on 100,000. No, the incidence rate was 120 on 100,000 among Swedish females ages between 20 to 32, and 200 on 200 on 100,000 among Spanish females from 12 to 22 years of age, and 270 on 100,000 in the Finnish twin females aged 14 to 19 years. That's according to the Eden et al. And we should also know that body shaming is common, like during the adolescence years, um, especially with teens, maybe in school and stuff like that. So for the prevalence rate is different among the various eating disorders, but with an anorexia nervosa, lifetime prevalence rate is 0.6 percent, which is 3 times higher in females compared to males. That's, is 3 times higher in female compared to male. It does not necessarily mean that males don't experience this. So this could be as a result of the fact that females tend to body shame each other more, and they care more about people's perception of their body rather than theirs. I'm not trying to be stereotype here, but it is common with with girls to be like, hey, oh, I'm more beautiful, I'm more slim and stuff like that, rather than guys. At times, guys don't really, most guys, they don't really care about having six packs and stuff like that. But with females, it's a whole lot of things. They want to, like, hey, they look at the mirror and look at the shape and stuff like that, and they start making wishes. Oh, I wish this was this, or I wish this part was this, or I wish my leg was smaller, or stuff like that. So when it comes to mortality rate, we're trying to look at how many people die from anorexia nervosa. So mortality rate gives us the number of people who die as a result of the cause, in this case anorexia nervosa, expressed as a percentage of the prevalence rate. In recent studies, after about 5 years follow up with people with AN, in patients with severe malnutrition, mortality rate was found to be as high as 15.9%. That rate is staggering, and this is really high. So I think measures are really needed for measures are needed to be put in place, or intervention should be applied to reduce the rate from increasing. Yeah, we need to try to get that rate down, as soon as possible. um so some of the signs and symptoms or manifestations are, so according to the Vacaros et al. 2021, some of the signs and symptoms of anorexia nervosa include terror of gaining weight. These people are really scared of gaining weight, and preoccupation with thoughts of food. They are like, when they just think of food, they are like, anxiousness begins, yeah, and they start feeling unease. They don't really want to see food. The view of self as fat, even when emaciated. um there's also peculiar handling of food, such as cutting food into small pieces. Most of these people, when in the presence of food, you see them getting their food, and they're like just playing with the food about and stuff like that. So they most often, in an inpatient setting, they need to be supervised, and maybe after they eat, you have to make sure they don't go and they don't go and throw up or something like that. So there's also peculiar food handling, such as cutting of food, pushing pieces of food around the plate. I mentioned that seconds ago. And there is also possible development of rigorous exercise regime. You see, these people are in the gym like maybe an hour. Maybe they go to gym twice a day. They spend like 2 hours every session. They are working the body so hard and starving themselves. And possible self-induced vomiting, which includes use of laxative and diuretics. So, and they also have maybe cognitive distortion, that is individual judges of oneself, control eating to feel powerful, controls eating to feel powerful to overcome feelings of helplessness. So some of the nursing interventions, uh, Vacarolos et al. 2021 outlines some important nursing interventions, which are worth noting, as acknowledge the emotional. And so for nurses, what we have to do is acknowledge the emotional and physical difficulty the patient is facing. That's very important. Assess for suicidal ideology and body harm, because most of them, they don't like, they don't have a good image about themselves. So also, we have to weigh these patients in the same clothes on daily basis, and at the same time every day, to have their weight, in check, and also monitor the patient before and after meal to avoid patient purging and throwing away of food, and after me. And most often, this could be done in inpatient, because if the patient is by their own, they can do whatever they want. So I think one of the main things for their treatment is, they need to have that willingness that, hey, I am working on this. I want to change about this. I want to work on this. At least, I want to lose weight, but I don't want to lose my key nutrients as well. Um, so nursing intervention continues. We also need to acknowledge the patient's distorted image, and how the patient perceives their body image without minimizing the patient's perception. We have to work with the patients to identify their strengths and their weaknesses as well. Educate the patients about the negative effects of ill weight, such as lack of maybe key nutrients, fluids, and electrolytes, and imbalances, and potassium and sodium, and all those nutrients that the body needs. So for advanced level interventions, we have a bunch of advanced level interventions. Pharmacologically, most often pharmacological approach towards AN, anorexia nervosa, is geared towards treating some symptoms of anorexia nervosa rather than treating anorexia nervosa itself. So we can target the symptoms. Maybe they can have symptoms of depression, they can have symptoms of anxiety, they can have symptom of so many other symptoms. So we should pharmacological approach targets those symptoms, and if those symptoms are targeted, overall it's gonna help the patient with AN. So according to Vocarolis et al. 2021, fluoxetine, a serotonin reuptake inhibitor SSRI, is sometimes prescribed for AN when weight has been stabilized to treat depression and obsessive compulsive symptoms. All right. We also have maybe advanced interventions, psychotherapy. These are like non-medicational approach. So apart from the pharmacological approach, psychotherapy has been proven to be effective in most eating disorders, including AN. Some of the psychotherapy used include cognitive behavioral therapy. This therapy is used to reduce distortion of persons thinking of their body image. It's a cognitive approach. Um, entails a lot of therapy sessions talking to this person. At the end goal is to change that person's perception about themselves, to make that person feel good about themselves, to make that person accept their image, their shape and size, or help them have the overall positive vibe they need to thrive. And we also have the enhanced CBT. It's also a cognitive behavioral therapy. This is structured and time limited for eating disorder. Like, what it means is it focuses to establish regular pattern of stable flexibility eating and addresses distortion of eating behaviors. And we also have like the dialectical behavioral therapy, which is a form of CBT which addresses emotional dysregulation, even though there is less evidence that it helps in anorexia nervosa. Also, okay, therapeutic communication has always and will always be a key towards optimizing patients' outcome. So, when therapeutic communication is used, it really helps the patient to express themselves. You know, some of we might just think therapeutic communication is like, hey, how are you doing? And oh, what are you doing? Or tell me, blah blah blah. Nope, that's not it. There are techniques in which we can use to prompt this patient to talk towards better to the medical practitioner better, and help develop a sense of trust in the therapeutic relationship, thereby increasing patient's outcome. So the overall goal is to increase patient's outcome. So the demonstration below is a hypothetical example of a therapeutic communication between a patient with anorexia nervosa. For example, in my presentation, I'm using a hypothetical patient called Emily, a 16-year-old high school girl, and a psychiatric nurse practitioner called Hunter. So I'm just using this as a hypothetical example to illustrate how therapeutic communication, the types of therapeutic communication we can use with a patient with an AN. So for example, okay, let's get started. This is Emilia. So Emilia states, Emilia is with Hunter right now in one of the regular patient visit, and Emilia states, I wish I was as flat as a pancake. Then Hunter replies, as flat as a pancake with a question mark. So, here, and Emilia said, oh yes. Don't you see how Adele looks? She was fat, and all of a sudden, she became so slim. I read an article online which stated that she will eat just one meal a day and drink just 1,000 mLs of fluid every day. I really want to lose weight just the way she did. So the above therapeutic communication involves reinstatement. So Hunter, this is Hunter, the nurse practitioner in this case uses Emilia's own words so that she can elaborate on what she means by as flat as a pancake. By elaborating, it enables us to understand her wishes and the reasons she is diagnosed with anorexia nervosa. So, and then Hunter said, okay, tell me more about how you want your shape to be. Then Emilia states, well, I want to be the slimmest girl in my class because I feel like the other slim girls make fun of me when I am in class and I feel very uncomfortable. So I have been cutting down on my food, and so you know what? Then Hunter said, I'm listening with a smile on his face. So Emilia said, anytime my mom packs my bag for my school with my lunch snacks and stuff like that, I throw them away in the school trash. I really do not want to eat like I used to anymore. Here, Hunter uses an open-ended question which allows Emilia to tell him her reasons of avoiding food and the strategies he uses to avoid food. So, okay, then Emilia respond, please do not tell, Emilia said, please do not tell my mom I get rid of my lunch, especially my mom, because she will be mad at me and I do not like that. All right. So Hunter said, okay, so if I got you right, and please correct me if I'm wrong. The reason you do not eat your lunch and snacks is because you want to get slim like your classmates so that they should stop laughing at you, and you do not want your mom to know you don't eat your lunch and snack as well. So, Hunter here summarizes their conversation and paraphrases her statement, which enables Emilia to know how worries have been taken into consideration and well listened to. Um, so uh, for the appropriate care setting for patients with anorexia nervosa, um, the care setting ranges from inpatient to outpatient care setting. Inpatient setting, like they make use of the milieu therapy. This is designed to treat individuals with AN, which includes an interdisciplinary team. The interdisciplinary team involves different team players, dietitian, um, psychologists and stuff like that. So this milieu therapy is purposely designed to assist the patients to establish more adaptive behavioral patterns, which include normalizing eating. And outpatient care may also be available to some individuals who experience some set of control or regulation over the eating pattern in the milieu therapy. So this entails a lot of discipline, and if put into and it puts the patient in charge of their own care, since they have an obligation to themselves to keep up with their treatment regimen. So stigmas associated with anorexia nervosa, you have like low self-esteem, insecurities about oneself, depression, fear of negative perception by others. It is most it's mostly confused as a choice rather than a mental issue. Some people like, oh, like you don't like eating, maybe that's a choice or blah blah blah. But they don't think that's a mental issue. There's something going on mentally right there. So, the perception about it is really different. So it is also downplayed, as most often the condition get worse before it is noticed. So with people with anorexia nervosa, they are already maybe they are already at that state before, like, hey, they want to be this awareness, or most often they're already on the way before it is noticed. So strategies aim at addressing stigma. So encouraging patients to accept their diagnosis and seeing a medical practitioner is very important. Encouraging patients to have a positive mindset about their current body shape and adhering to treatment regimen is very important as well. Then we can also offer empathy to the patient concern and focus on how the patient feels rather than the food, rather than rather than the food, because um, there's a focus on how the patient feels rather than food, because what they feel makes them not wanting to eat anymore. So we should focus on how they feel rather than the food. So in summary, most people do not recognize the impact of eating distortions effect, the impact eating distortion affects on the overall body metabolism. To some people, it is often not diagnosed because they do their best to mask this disorder, whereas the case might be whatever the case might be. It is essential to seek for, it is always and always good, to seek for medical help, because evidence-based practice has proven that um AN can be treated if the patient meets up with a compliance of treatment regimen. And also, as a healthcare worker or provider, it is vital to understand the pathophysiology of AN and other eating disorders to help manage symptoms using therapeutic communications and both pharmacological and non-pharmacological approach. Um, you also have bulimia anorexia. There's maybe about 3 to 4 or 5 different types of eating disorders out there. It is very essential for healthcare providers, or workers, to know the differences. So that's it about the summary. And for my references, here are some important links. You can visit some of these links to read more about anorexia nervosa. One of the most helpful resources was the Elizabeth M. McCullis et al. Essential of Psychiatric Mental Health Nursing, the fourth edition, 2021. And I also made use of the Mayo Clinic. You have the link over there. Those are very important links. You can, use those links, and it will greatly help you to understand the pathophysiology and the epidemiology and the etiology of anorexia nervosa. Thank you and have a good day.